Hello, I'm Jan Leifman.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker and Dr. Ruben Mesa. Dr. Mesa is the executive director of the Mays Cancer Center at UT Health San Antonio, MD Anderson.
In today's presentation, Dr. Mesa discusses the use of JAK inhibitors as a therapy for myeloproliferative neoplasms.
Did you know that Dr. Mesa contributed to the US FDA's approval of ruxolitinib for polycythemia vera and myelofibrosis, and also fedratinib for myelofibrosis? He also led the development of the first US NCCN's panel guidelines for the diagnosis and treatment of myelofibrosis, polycythemia vera, and essential thrombocythemia.
He definitely is an inspiration in the field of medicine.
So let's tune in and learn from this global leader.
Now let's pivot toward myelofibrosis. Myelofibrosis is the most severe of the MPNs, the most likely to cause premature mortality and morbidity. So it is natural that many agents have begun their testing in myelofibrosis before evolving to eventually be in polycythemia vera or essential thrombocythemia. I've used the story a couple of times this year. It's now been about 30 years since I saw my first myelofibrosis patient as a first-year medical student at Mayo Clinic in Rochester, Minnesota. And that patient, it was very tragic. She was a young woman. She was from Venezuela. She was in her early 30s. She had a massive spleen. She had a splenectomy because we didn't really have much else to do to help the disease in those days. She died of splenectomy-related complications only a few days after I first saw her, working alongside my mentor at the time, Dr. Ayulu Teferi. That got me very interested in these diseases, trying to understand why such a significant burden. We were involved in many clinical trials, and in the first 15 years of my career, we really did not make a lot of progress. We were trying to beg, borrow, and steal drugs from other indications, usually without a lot of success. It was in 2005 that the discovery of the JAK2 V617F mutation was a watershed moment, both in, I think, recruiting additional scientists to study the disease and try to expand our knowledge, but also to energize partners in the pharmaceutical industry to find, now that there were potentially druggable targets, ways to specifically try to help MPN patients. Since that time, we have now seen the approval of 3 drugs in myelofibrosis and several others on the cusp of approval. Ruxolitinib, fedratinib, and now pacritinib, most recently approved. And closest on the horizon, momelotinib, as well as ruxolitinib combinations. There have been many agents that have come and gone that were tested, and either due to toxicity or the competitiveness of the field are no longer in development. Ruxolitinib was the first of these and really became a cornerstone therapy for these diseases. It's made a huge impact. Approved in November 16 of 2011, approved on the basis of the phase 3 trial that Serge Verstavchik and I led in North America of ruxolitinib versus placebo, and the European study led by colleagues of ruxolitinib versus best alternative therapy. And this showed significant improvement in splenomegaly and symptoms, clearly and vastly superior to placebo or best alternative therapy. Now, over time, we have seen another very important observation, and that is an improvement in survival. The trials were not designed as survival studies. However, it became fairly clear relatively early on that patients lived longer. They lived better, but they also lived longer. And that the length of life seemed to not be easily explained solely by improvement in debilitation, greater levels of energy, all of which were things that they had. They had decreases in splenomegaly, but we didn't really think that the decrease in the mechanical effect of the spleen really was mechanistically the reason for improvement in survival. These are nice data that were gathered by our colleagues at MD Anderson that showed not only a decade improvement in survival, but really tying it with the exposure to ruxolitinib. Why is this the case? I think it's multifactorial. I think there may be less inflammation. I think there may be a less toxic bone marrow microenvironment, less likelihood of progression toward acute leukemia. There's not a plateau, so it does not cure the disease, but the impact is real. Indeed, I saw in January of this year a patient that had gone on the COMFORT study back in 2009, and now coming to see me in 2022. I went back and calculated, well, what would have been the individual's prognosis if we had looked back in 2009? And their estimated survival by the DIPSS at that point was under 3 years. And here it was almost 13 years. Still on ruxolitinib. Now, the patient was coming off of ruxolitinib. They were now having some evidence of progression, and we put them on a clinical trial. But their survival was 4 times longer than it would have been otherwise. So a very significant advance, but still room for us to grow. Now, a couple important lessons we have learned over time. One, the dose of ruxolitinib you use matters. There's probably too much underdosing of ruxolitinib in the United States. You have to use a sufficient dose if you're going to have an expectation of improvement in survival. Ideally, 15 milligrams twice a day or more. Fedratinib, now approved since August of 2019. This is also a JAK2 inhibitor, such as ruxolitinib. It's a FLT3 inhibitor. It was approved on the basis of 2 trials, the Jakarta study, which was the upfront study compared to placebo, and the Jakarta 2 study, a second-line study that I led along with Professor Harrison from the UK. The Jakarta study with 2 different doses of fedratinib, the 400 milligrams now being the FDA-approved dose versus placebo with the potential of crossover with improvement of splenomegaly or symptoms as the goal endpoints. What was seen was clearly fedratinib was vastly superior to placebo alone. The 400 milligram dose was chosen because it was the best combination of efficacy, and it was a better tolerated dose than 500. 500, you might get a little bit more of efficacy, but you gain a lot more in terms of side effects. So what side effects? One, there are common and then there are rare. It can cause cytopenias, as can ruxolitinib. On the rare side, there was a small number of individuals that developed a neurologic event that appeared to be like Wernicke's encephalopathy. Over time, thiamine levels were found to decrease in these individuals. It's unclear whether those initial individuals really had Wernicke's encephalopathy. But on an abundance of caution, the FDA had put the drug on a hold and now approved, but with a black box warning, monitoring for Wernicke's replacement of thiamine. Much more common side effects, it can cause some GI side effects. This is a bit incremental compared to ruxolitinib, and typically do begin patients with either antidiarrheals or anti-nausea drugs to avoid or to control these side effects. So if I'm using fedratinib in the front line or in the second line setting, I'll start at 400 milligrams a day, assess thiamine levels in alignment with the FDA black box guidance, replace thiamine if it's low. I'll start them on fedratinib, give them PRN nausea or antidiarrheal medicines. I'll be honest, in my practice, I still typically give them thiamine. Thiamine's cheap, really aren't a lot of downside. I give them 100 milligrams. You get 100 pills at CVS for like $9. Not a lot of downside. And then we monitor response, monitor for GI toxicity. Usually those GI concomitant meds can be discontinued, and we'll continue them on thiamine. There were updated data regarding the FREEDOM study The FREEDOM study is an additional kind of post-approval study in fedratinib, monitoring thiamine, giving thiamine, and both that with the GI prophylaxis, patients are able to tolerate the drug, they're staying on the drug, and we're not seeing any episodes of Wernicke's encephalopathy in patients appropriately treated. Jakarta 2 was the second line study that again showed benefit in individuals that failed ruxolitinib. These were updated data that I presented in a series of meetings over 2020 and 2021, and is a helpful backup option. In 2022, if a patient has failed ruxolitinib, fedratinib should be your preferred option as second-line therapy for an individual with a platelet count of over 50,000, especially if they do not have access to a clinical trial. Fedratinib, approved the most recent at February 28th of 2022. Now, this drug is a little bit different spectrum of action and a little bit different set of patients. These are more these cytopenic patients with myelofibrosis, lower counts. They tend to more often have primary myelofibrosis. They tend to be JAK2 negative. They have a higher risk of acute leukemia. This is a JAK inhibitor, but it's also an IRAK1 inhibitor that may change its spectrum of activity and may allow it to be more successful in this subgroup of patients. In studies, it has been seen. This were the PERSIST-2 study for patients with a platelet count of under 100,000, showing improvement at 200 milligrams twice a day compared to either ruxolitinib or once a day for control of splenomegaly and of symptoms. And indeed, the 200 milligrams twice a day is the recommended dose. As one would expect, the platelet count was stable for these individuals to improving. Again, it's not a platelet therapy. What this allows is the ability to use this medicine in individuals with a platelet, irrespective of platelet count, but that it is safe for individuals with a platelet count of under 50,000. And as such, it is unique amongst NPM therapies and having been tested in this group of patients and found to be safe. There also can be improvements in anemia. And again, here data from my good friend and colleague, Jan Mascarenhas, showing improvement in rates of transfusions. Side effects, again, GI-related side effects, so it overlaps a bit with fedratinib in that setting, as well as can cause cytopenias. This too now is approved, here showing the FDA label with its trade name of Vonjo, 200 milligrams twice a day, with or without food. It is for platelets, individuals with myelofibrosis with a platelet count of under 50,000, whether that be frontline or second line. Now, there are not many patients that are frontline that have a platelet count of under 50,000, but if so, surely consider this. The fourth JAK inhibitor is on the cusp. It is seeking approval, and I had the honor of presenting the data from the phase 3 study just again at the ASCO meeting just about a week ago of this phase 3 study, momelotinib versus danazol in symptomatic and anemic myelofibrosis in patients that previously treated with a JAK inhibitor. Here, this JAK inhibitor also inhibits ACVR1. So this is the flip side to the hepcidin story. You heard earlier we were trying to mimic hepcidin to control erythrocytosis in vera. Here we try to decrease hepcidin through the inhibition of ACVR1 to try to improve anemia, improve erythropoiesis. There have been previous important studies with momelotinib. This JAK1 and JAK2 inhibitor, in addition to ACVR1, in the SIMPLIFY-1 study, which was the largest randomized study compared to ruxolitinib, it showed non-inferiority for control of splenomegaly. It showed rates of transfusion requirement. Momelotinib was superior to ruxolitinib. In improvement in symptoms, we saw about a roughly 30% improvement in myelofibrosis symptoms, both in Simplify 1, that upfront study, and Simplify 2 in the second-line setting. It was slightly inferior to ruxolitinib as related to symptoms, but better with anemia. There was still felt to be a strong data gap in the second-line setting to round out the registration profile for momelotinib, which was critical, so we designed the Momentum study. Here, these were individuals that were symptomatic. They were anemic. They had previously been treated with a JAK inhibitor. So 195 patients were randomized in a 2-to-1 fashion, momelotinib plus placebo versus danazol plus placebo, with a momelotinib open label crossover with endpoints of total symptom score response and secondary endpoints of transfusion independence and splenic response. This study hit all of its endpoints. First, a clear improvement in symptoms, which was a primary endpoint compared to danazol. Second, a clear superiority for improvement in splenomegaly, whether one uses a cutoff of 35% or 25% volume reduction. This is the second-line setting. Indeed, we've shown in the past that a greater than 10% volume reduction in splenomegaly was associated with improvement in survival. For transfusion independence, the goal had been non-inferiority, but was really close to showing overt superiority over this active control arm. Rates of transfusion independence rose from 13 to 31% on momelotinib versus 15 to 20% on danazol. And you see here on the right, the really superiority of momelotinib, and then the kind of correction of the danazol arm up to momelotinib levels after crossover. In terms of toxicity, GI and some low-grade cytopenias. Again, so you're getting a sense many of these new agents do have some overlap in terms of toxicity. GI and watching the counts tends to be a recurring theme. The study was not designed as a survival study, partly because of the period of observation, the need for crossover. That being said, there certainly is a strong trend toward improvement in survival of momelotinib versus danazol. And this is despite the fact that there was a bit of an imbalance of death due to COVID. So this study completely accrued during the time of COVID. It started accrual in April of 2020, and particularly during 2020 pre-vaccination, there were 6 deaths on the momelotinib arm and 1 on the danazol arm. We certainly have not seen, after things have kind of normalized in the COVID world, that there has been any significant issues. So a lot of issues pre-vaccination. Certainly JAK inhibitors and COVID have been found to have some interaction, particularly in the pre-vaccine setting. There is some data that danazol may actually have some protective effect against COVID. These data build on some of our prior observations that there may be a survival advantage, and that survival advantage may be tied to an achievement in transfusion independence. Indeed, from the Simplify studies, this was an analysis that previously presented that's being considered for publication as we speak, or it's in press as we speak. You see here the difference in survival. So how do the JAK inhibitors fit together? Well, one, if we think about the spectrum of myelofibrosis patients requiring therapy, greater than symptomatic low risk. If you have proliferative frontline, ruxolitinib is still our cornerstone in hopefully an appropriately dosed fashion. Second line, proliferative, fedratinib. If you have cytopenic myelofibrosis, pacritinib is your frontline option, particularly if the platelets are under 50,000. I think if momelotinib becomes approved, I think there will be some delineation between patients where anemia is the main driver and a consideration will be momelotinib, or whether thrombocytopenia is the main driver and it'll be pacritinib.